Good afternoon, and welcome to our September webinar, a collaborative presentation by the Parent Training and Information Center and the Recruitment, Training, and Support Center at the Federation for Children with Special Needs. My name is Renee Williams, and I am the Interim Program Director at RTSC. Our technical producer is Hannah Stahlkamp. Today's webinar is Understanding the Invisible Disability of Fetal Alcohol Spectrum Disorders, FASD. Our presenter today is Enid Watson from the Institute for Health and Recovery. On behalf of the Mass Department of Public Health, she is the Massachusetts FASD State Coordinator. In addition to systems development to address FASD in a variety of settings, Enid provides training to many programs and agencies, including DCF, DDS, DYS, early intervention, substance use treatment programs, and probation officers. During the webinar, please type your questions in the toolbox and feel free to engage with other attendees. We will leave time at the end of the hour to address the questions. If your question is not answered live, please send us an email and we will do our best to follow up with you. If you're interested in learning more about the Federation, please go to our website at www.fcsn.org and explore all the different programs, including how to volunteer to become a special education surrogate parent or attend one of the many trainings presented by the Parent Training Information Center. Welcome, Enid.
Thank you. It is lovely to be here indeed. So I'm going to ask you if any of you work with any parents. I know that you're all parents of some kind or another. And if you work with any parents who have any difficulty getting things done. And you can see this list of possible issues. I'm not going to read everything on the slides because I have so much on each slide. I do apologize. But these are adults who just can't seem to succeed in life in spite of earnest trying and assistance. Now, some of you may know the biological mothers of some of the children that you are parenting. And here is just a list of some of the characteristics that many women who give birth to a child with an FASD might have. Any woman in any demographic category can give birth to a child with an FASD, but these characteristics here are the ones that are typically present in a woman who drinks during pregnancy. Now, this is something that you might know more immediately because some of you perhaps have babies and other children, and these are the babies that just can't seem to feel comfortable in their own skins. They cry easily, they're really irritable, their motor skills are off, they're behind in some of their developmental footsteps. Very insecure attachment, a lot of difficulties with sensory integration, which could be lights or sound or the feel of a blanket on their little bodies. So now, not all the babies that have these characteristics have an FASD, so don't be alarmed. It's when we put the package together that we are concerned. Now, for those of you who are parenting kids who are in school, kids with an FASD often have problems with math skills and abstract reasoning. They may be able to read the words but not understand what the words mean. And you'll see some of these other issues. Poor impulse control. A lot of kids have that, but perhaps not to the level that our kids have who have an FASD. And please let Renee know if I'm going too fast. Okay, so now I'd like you to meet Fred. He's 7. and he's in foster care, and he's a trauma survivor. As you might imagine, the biological parents of these children often have a lot going on. You could see that from my maternal risk slide. And the children can be very challenging to parent, and so there's typically a lot of trauma in their backgrounds. Now you'll see he has some familiar diagnoses: post-traumatic stress syndrome, attention deficit disorder, oppositional defiance disorder, though we'd call it something different, I think, now, learning disabilities. But look, the little guy has an IQ of 75, which is above low normal. So he's got a pretty good IQ, but look at how he's described: explosive, avoidant, easily frustrated, socially inappropriate. Oh, and by the way, this isn't really Fred. And here are some of the primary characteristics that Fred has. You'll see that he functions at half of his chronological age. He's easily overwhelmed by lights and noise. Language, you can't tell looking at him, but he only hears every third word. He can't store memory, the things that he's just heard, and then retrieve them. And he has troubles with abstract thinking, planning ahead, implementing. That's all under the rubric of executive functioning. Now, here are some interventions that were available to Fred, and these are interventions that are quite common for children with behavioral issues such as Fred, and you can see all of them, and you would think that all of them together would really help Fred, but they didn't. He was in a special school. They did all these things, and he still had daily meltdowns, and they needed to restrain him. So I'm going to go back to Fred later on in our webinar. Oops, this one we've already done. So sorry. We've done this. Okay. Now, here is, I'm going to ask you to stretch your imaginations for a moment. Pretend for just a moment that heroin is legal, that there are only sterile, clean needles in the world, that there's no crime or abuse or anything. Just pretend that it's a safe and not problematic thing. We're talking about fetal exposure here. So we have the safe context for heroin. And so given that, if you had a pregnant woman who was drinking alcohol, shooting heroin, or smoking cigarettes, which drug would you want the mother to give up first? You can think. Now, I wonder how many of you said heroin first, which is what most people do when I'm in face-to-face trainings. In fact, alcohol is by far the most dangerous drug for fetal development. And the second most dangerous drug, the other legal one, cigarettes. So I'm not telling you, or I'm not recommending that you go up and encourage pregnant women to shoot up heroin, not by any means. But the opiate derivatives are not as bad over a lifetime as alcohol and tobacco. So the Institute of Medicine calls alcohol a poison, which is what a teratogen is. And so of all the substances of abuse, alcohol produces by far the most serious neurobehavioral effects in the fetus, and we're going to go over some of them. Now look at this penny. Pretend that it's an actual size penny in your palm, and you see the date 2012. If you had an embryo that was small enough to fit into the zero in 2012 on an actual penny, that embryo could be adversely impacted by alcohol exposure. let's get into some definitions. You'll never find anyone who has a fetal alcohol spectrum disorder. It's not a diagnosis. It's an umbrella term that describes the range of effects that can happen to a child whose mother drank during pregnancy. The most severe end of the spectrum is full-blown fetal alcohol syndrome. We now have, in the clinical DSM-5, another diagnosis, neurodevelopmental disorder associated with prenatal alcohol exposure. We rarely will get a child who has alcohol-related birth defects, but no cognitive problems. That's unusual. And then we sometimes get children who have partial FAS. What I want to say is that I'm going to say a lot of things in this webinar about how difficult life can be for individuals and families who are affected by FASD. Their effects are irreversible. However, it's really important to remember that people with an FASD can grow and have wonderful lives. They'll just be different lives than anyone expects. I'm not going to give you brain damage 101. I'm just going to do a brief introduction. What I want you to take away from this slide is that all these areas of the brain can be impacted by prenatal alcohol exposure. It's very important to remember that when children and adults don't react the way that we expect them to, it may not be because they don't want to, but because they have a brain disorder. And I'm going to give you some examples of this. Now, here is a brain, and you'll see on the left an arrow that's pointing to a little white, it almost looks like a bridge, a little arch, and that's the corpus callosum. And the person on the right, you can barely see their corpus callosum because they have full-blown FAS. Well, what does that mean? In lay terms, which is about all that I understand, the corpus callosum is the bridge between the hemispheres. So what this means is that Fred may be able to receive information, but he can't transfer that information to the other side of his brain, which makes it hard for him to recall it later when it's needed. Now, these are the major points for physical diagnosis. Is a small head circumference, and this isn't just because somebody may be petite. This would be a small head circumference compared to the other children in that biological family and below a certain percentile. They often have poor motor coordination, fingers, legs, arms, and then it's the long range of cognitive disabilities, and you can see there are a lot of them. And one of the unfortunate side effects of having one neurological disorder, which FASD is that if you have one disorder, you're at increased risk for developing other neurological disorders. So here's a list of common disorders that co-occur with an FASD. Attention deficit, ADHD, I think you all know what that is. The reactive attachment disorder and sensory disorders are in red because they're highly prevalent in FASD. Many of these other disorders are very common with an FASD. Eating disorders, when they're young, the children may not eat, and when they're older, they may overeat. Anxiety is very common, depression, all of these issues. We hope that that there's not a child with all of these at the same time. And I mentioned here in some cases, there's also greater deficits in their verbal and perceptual reasoning, which means if you show a child a picture of a ladder and ask them to make a copy of the ladder, instead of just drawing two parallel lines and then putting horizontal lines between them, they'll try to make individual boxes that don't quite fit. So people often say about kids with an undiagnosed FASD, they're oppositional, uncooperative, they don't listen, they don't try, they're not motivated. But what the real truth is that they have brain damage, and that it tends to be an invisible disability. And so these are the people who just can't seem to get ahead in life. And it looks like when you have kids or adults in your lives that have some of these characteristics, we tend to view them through a moral lens and saying they're just not trying hard enough. In the world of FASD, it's not trying harder, it's trying differently. So let me give you an example. Say we have Sally, who has oppositional behavior, oppositional defiance disorder. She doesn't do her task. Why not? She doesn't feel like doing it. So what you would do with Sally is you provide her a positive sense of control and work out some consequences and limits, and then she'll do the task. We have Fred, who doesn't come, no, not Fred, let's use Frank. Frank doesn't do his tasks because he's got ADHD and he's got too much stimulation going on, and he gets distracted. So with Frank, you'd limit the stimuli, shut off the television and radio, put him in a room without the other kids, and give him some little cues, and he'll do the task. Now, Tanya here with FASD doesn't complete her task. Why? You may have said to her, go upstairs, change into your play clothes, pick up your room, do your homework, and come down in 30 minutes for dinner. Well, Tonya wants to complete the task, but she goes upstairs and she can't remember the list that she's supposed to do. And so she sees her toys and she sits down and plays with them and gets in trouble. Did you hear what I said? So with her, we'd want to give her one direction at a time. And a lot of people don't think it's really important to get the diagnosis of an FASD. We think it is, because until we know how that person learns and perceives the world, we can't address any of these other issues in his or her life. Now let's talk about language. Early language development may be delayed, and often people with an FASD can be very verbal and friendly and outgoing. However, if you talk to them for a while, you'll see that they're really recycling a lot of what they said instead of just adding new information. So they can usually talk a good talk, which is expressive language. However, because if you remember that corpus callosum that's missing, when they hear your words, they have trouble receiving that and processing that in their brain. And so they may not have any idea what you've really said, even though you just said, do you understand? And they say yes. This is often perceived as purposeful, oppositional, or uncooperative behavior. Please forgive my lack of commas. So here is an example, and this is true. There was a young man who was functional enough that he could have a driver's license, and he was stopped by a police officer for driving under the influence. He was weaving all over the road. When they stopped him, he had an open container of alcohol on the front seat. His breath reeked of alcohol, and he could not pass the field sobriety test. Well, when he eventually went before the judge, he said to the judge, I never drink and drive. I know you're not supposed to do that. I only drink at the stoplights. Now, this is someone who wants to do the right thing, but just thinks very literally. And maybe they're supposed to see their probation officer on Wednesday, and they skip their appointment. And we say, well, didn't you see your probation officer? Oh, yes, I saw her when I was grocery shopping. So again, we have to be very careful. Take a shower. You have to make sure, take a shower, take off your clothes, get under the shower, turn on the water, get a face cloth, put soap on it, wash your body, rinse off, shut the shower off. After a while, people will learn what it means to take a shower. And what is verbal receptive language the basis for? Everything, the world. So you can imagine that people who do not have good verbal receptive skills, people with an FASD often get into a lot of difficulty. Social situations. People are often act younger than their chronological age. And so they may act half their age, which would be inappropriate. And they don't often filter what they're saying. They can be very naive, and they'll just say whatever's in their mind without realizing that it might be disruptive or rude. They often have difficulty with peer relationships. These are the kids who never get invited to birthday parties. They may laugh at a joke, but not really understand it. They laugh because everyone else is laughing. And they're very naive and gullible, and they're easy marks for manipulation and abuse. There was a study done by Ann Streisguth about what are some of the secondary disabilities of people with an FASD, and I should have put 100% under academic problems and behavioral difficulties, because all of the kids with an FASD will have these problems at varying levels. But you can see a high dropout rate, a lot of trouble with the law, mental health, drug problems, alcohol problems, and also multi-generational FAS. Though I will say the only way a child can have an FASD is if the mother drank during that index pregnancy. If the mother has an FASD herself, it's not genetically transferred, only if she drinks during pregnancy. Now, how much FASD is there? More than we think. Now, I made up this slide, and I want you to look at the different levels. Some of you may know that there's a new piece of legislation was passed that allows children with autism spectrum disorder and these two others, Smith-Magenis and Prader-Willi, to qualify for developmental services at the Department of Developmental Services, even if their IQ is over 70. And you can see that, and FASD was not included in that group. And you can, conservative estimate is that there are almost 2,000 children born per year in Massachusetts with somewhere on the FASD spectrum. The problem is these children are mostly undiagnosed. So let me just say a little bit. We get a lot of people come to us and say, oh, I think my child has autism spectrum disorder, or I think my child has both FASD and ASD. And frankly, it's very rare that they're together in the same individual. FASD kids or adults with FASD are typically socially disinhibited. They'll talk to anyone, anytime, any place, and it gets them in trouble. They'll go off with strangers who could be dangerous. And the ASD kids and adults tend to be more asocial or have a social disinterest. So they're really on opposite ends of the sociability continuum. There's a study that was just done earlier this year of foster or adoptive children who were referred for mental health assessment. And of these 547 children, over 86% of the youth with an FASD had not been previously diagnosed or misdiagnosed. So you can see that there are a lot of children out there with the wrong diagnosis who are not thriving. Now, there are things that help. We know that living in a stable or nurturing home, the kind of homes that you all provide as surrogate, foster, or adoptive parents, early in life is really important. And if there's no history of physical abuse, ideally, the diagnosis would happen around the age of 6. Nationally, internationally, the researchers are looking at kindergarten, first and second years of school for a good a good age to diagnose. The kids in early intervention often don't develop the developmental delays until they're in their second year, and then they nearly age out of EI. It's interesting that the kids and adults with FAS, the full-blown, most severe end of the spectrum, fare worse than those with the lesser end of the spectrum, and that's because children and adults with the full FAS facial features are more easily identified and diagnosed than people with lesser effects. So those are the protective factors. Now, I want to introduce you to Julie and her family. I've met Julie quite a few years, and she's one of my heroines. And Hannah right now is pulling this up. She's a wonderful production assistant doing all this. I can't hear it. Well, we're having technical difficulties. You can't hear anything, but you can see the words. It's not as good. There's little Julie.
Well, perhaps while Hannah is working on those, we can address some of the questions.
Yes, let's do that. It's not fair for women, but if a man is inebriated at the time of conception, as far as we know, there's that child will not have an FASD. The child can have an FASD only with in utero exposure to alcohol.
Okay.
The child may be affected genetically by other parts of the sperm. Okay.
Okay, another question. It's more of a comment someone made, that the guilt of the mother must be substantial.
Oh, you're so kind to recognize that. I don't think that there's any stigma greater than the stigma toward a pregnant or parenting woman who uses substances. And we know that a woman never uses substances during pregnancy to hurt her unborn child. Otherwise, in this day and age, she would terminate the pregnancy for the most part. So it's wise to be sensitive to these women. And there's a wonderful national organization for birth mothers of children with an FASD that helps them overcome stigma. Now we have another specialist here who is trying to work on the sound. Do we have any more questions?
Absolutely. Another question from Sandra is, it appears that this would be mixed diagnosed. Is that correct?
It's often misdiagnosed, and we want to increase the diagnosis. So families and programs and state agencies and schools will all have better outcomes.
Okay. Another question, I think I referred to the slide where you mentioned which would be a more dangerous impact, the alcohol, the cigarettes. The question is, how do we know that the research on opiates is not yet in?
There's enough of the research in opiates that gives us that information. I've done a lot of work with substance-exposed newborns and mothers and child welfare addressing this issue. And there has been significant information done. However, you are right that we don't have any longitudinal studies. But we do know that with the proper postnatal environment, from what we know now, from what the research says now, the children who do experience neonatal abstinence syndrome, if there was no alcohol consumption or tobacco use, tend to fare well.
Okay. FAS preteens and older will often do well and welcome a list instead of the verbal instructions.
Yes.
I think that's referring to the list that you said. You stay in the shower, you go through the different steps.
Absolutely. They love a list in one direction at a time. Good point.
Another question, are children affected with FASD eligible for DMH services where it is not a DSM diagnosis?
It is a DSM diagnosis now, but DMH still won't take our kids. And we're having a lot of problems with that. They will take them if they have significant co-occurring disorders and have other mental health problems, which they do. However, most of the kids that they'll never get in just on FASD, nor will they get into the Department of Developmental Services with just FASD if they have an IQ over 70. I apologize. We're not going to be able to show you Julie. She's going to send Hannah's going to send the link, and you'll want to do it. And Julie has a whole group of children who have different ranges of FASD. And then there's a surprise at the end of Julie's story that will move you to tears. And am I speaking too loudly? How's that? Can you all who are participating are being very patient with us in our sound, in the video. So I hope that you can take some time to spend 4 minutes and 20 seconds with Julie and her family. So let's talk about interventions. We need a lot of help. And it takes a village and a group, by all means, to work together. So one of the things that's important is that, as I mentioned earlier, people with an FASD may have a good IQ. I just met somebody last week that has a 95 IQ. However, he cannot live up to his IQ. His IQ, knowing his IQ is 95, he doesn't have the skills to adapt to different situations. He can't excel in school. He can't perform to his IQ. And he just, it's sad and it's frustrating. So remember Fred. Fred This is an old diagnosis. We try not to use this anymore. Static encephalopathy means that the brain doesn't change. And in fact, the brain still does change and grow, especially if we start with somebody who's young and the plasticity of the brain is still in place and undergoing change. But Fred, in fact, does have an FASD. So how did we then work with Fred? So we know he acts younger than his age. So instead of treating him like a 7-year-old, we expect that he'll act like a 3-year-old, even though he has a 7-year-old body. So we adjust our expectations of Fred accordingly. It does us no good to punish him for doing something that he doesn't understand. He doesn't fully understand. Fred has a lot of memory problems. Repeat, repeat, repeat. Every day is a new day. So on Monday, Fred may know his primary colors because you went over them with him 30 times. On Tuesday, he may not remember them. Eventually, with things like those colors, the more you repeat, eventually he should be able to remember them. Now, this is not true for more complex problems, obviously. Slower auditory processing. He won't list. He can't process a list. So you slow down. You use fewer, simpler words. And as one of you already mentioned, perhaps you'll do make a list, or you'll go one direction at a time. Children and adults with an FASD often have a lot of trouble with transitions. I know a parent who would drive home and say to her child, "We're driving into the driveway. I'm stopping the car. We're getting out of the car. We're walking up to the door. We're going into the door. We're taking our jackets off and hanging them up. We're going into the kitchen to have a snack." Hopefully she doesn't have to do that forever until the child or other person understands about what is a safe transition and what isn't. So when we're faced with rigidity and perseveration, just obsessing over one thing, we have to just do fewer tasks and slow everything down. A lot of people with an FASD just can't sit still. And so we don't make Fred sit still. We let him get up during English to walk around the room or in special ed, wherever. And these are the basics of FASD adaptive functioning interventions. And guess what? When people worked with Fred with this kind of approach, his tantrums ended within a week. It's simple, but not easy. So what we need to do with people like Fred is change our expectations and look differently. Now, Fred, because of his brain disorder, doesn't process words well and ideas, and he can't remember them. He can't pull them back from the other side of his brain. So when you ask him to describe something, he's so eager to please that he fills in with what he thinks is going on. We perceive that as a lie, but he really isn't trying to lie. He's really just trying to please. A lot of times it looks like he just doesn't show any feelings, that he doesn't care. But in fact, he has a hard time expressing what feelings he has. He seems lazy. In fact, he's trying very hard to do something that he can't do, and he could be discouraged. And again, something as simple as resisting, a lot of times he's not resisting. He just doesn't really understand how to get it, even though you may have explained it to him every day for 2 weeks. You may need to explain it to him again, one step at a time. And instead of saying, do you understand me or do you get me, because he wants to please, he'll say yes. You'll say, explain to me what you're going to do right now. And then he'll explain it to you, and you'll both be on the same page. Now, a lot of what we do with children with an FASD are adaptive interventions, and I'm going to give you some examples. These lovely people often have difficulty with facial recognition. There may be some a young man sees a teenager with an FASD. He walks down the street and he sees a pretty young girl smiling at him. He thinks, even though he hasn't met her, that she's smiling at him because she loves him, and he'll go up to her and hug and kiss her, and suddenly he'll have a sexual offense. He doesn't understand. So we do a lot of social skills training. He may see his parents hugging and kissing, or his surrogate parents hugging and kissing, and thinks that he can do that with anyone, or she can do that with anyone. I will say that for girls, girls and boys are both equally liable to be victims of sexual and criminal abuse. And the boys are more likely to be perpetrators, not in the traditional sense, because they don't really understand why. Safety skills. Because people with an FASD often have poor perceptual reasoning, they have trouble knowing when it's time to cross the street. Now, I live in Boston, and sadly, I've gotten to be very good at jaywalking. Though now with my granddaughter around, I've gotten much better about following the signs. I can tell when there's a car far enough away that I can dart across the street and get hit. People with an FASD can't do that so well. So now there's a new video game that actually teaches people how to know when to cross the street. The number of pedestrian deaths with people with an FASD is just heartbreaking. Now, I'm going to have to tell you that people with an FASD, I've told you before, are very literal. And so I can't tell you how many bananas never sired a baby because at the time of sexual intercourse, the condom was on the banana and not on the young man's penis. And we are very literal. Often we teach young men about contraception by putting a condom on the penis, but we do need to take the next step with them and make sure that they know that where the condom is supposed to go. Now, we know that FASD is 100% preventable, and it's the leading known cause of preventable non-genetic and intellectual disabilities, and can be caused only if a woman drinks alcohol during that index pregnancy. So here's the public health message, is that we do not want women who are pregnant or planning on becoming pregnant to use alcohol, marijuana, illegal drugs, or tobacco during their pregnancy. That's the public health message. For all of us, though, I want to say we do not want women to terminate a pregnancy because they drank before they knew they were pregnant. It's never too late to stop drinking. And depending on how much alcohol was consumed during pregnancy, that child may or may not be affected. We won't know, but it's we want a woman to stop drinking, ideally before she conceives, but then at the first moment that she knows she's pregnant. This is a new health advisory policy developed at the Bureau of Substance Abuse Services, Department of Public Health. I helped with this. This is for OBGYNs across the state. There are some great OBGYNs across the state. There are also some who say, oh, it's okay to have a drink now and then during pregnancy. That much isn't going to hurt you. However, if you say that to a woman who's struggling with her alcohol, she may hear, oh, my doctor said it's okay to drink every day, and that drink may be a bottle of wine or 5 beers. So we want people to know there is no safe amount of alcohol. Now, I only have a couple more slides, but I'm out of time because we didn't have I'm out of most of my slides because we didn't get to see Julie and her family. So what kind of questions do you have?
Okay. One of the questions I have here from Sandra is, can these students be in the mainstream?
That's a good question. Can these students be in the mainstream? Sometimes, depending on the severity of the disorder, they can be. And I just met with the Department of Special Education at the Commissioner of DESE's office, and they say that they classify children according to what they can and cannot do as opposed to what their diagnosis is. So they, sometimes kids will go into the mainstream and sometimes they won't. I will say that most of the children that are in our Massachusetts task force now are not mainstreamed. And I want to take that moment to say we do have a state task force that meets quarterly at the Department of Public Health in Boston. And we also have a network, a Massachusetts network of families of children with an FASD. At this time, they're all adoptive or fostered families. We would love to have some biological families too. And if any of you would like to join our network, it's for families, it's for support and advocacy, because we all know that we need to get the word of FASD out there in the public. Please let me know, and Renee and Hannah will get my email to you.
Okay, great. Another question. Can you discuss how assistive technology is being used to help these kids in high school and beyond? Calendars, apps, notifications, iPhone, sharing technology.
That kind of sharing technology has been magnificent for people with an FASD. It's helped in so many ways. As a matter of fact, it's so helpful that some parents have trouble getting their kids to put their devices down or to move away from devices because as I mentioned, often the children or young adults, teens, have poor social skills. They have unrefined social skills. They're very social. And so a lot of times people don't want to do things with them, and so they're very comfortable with different kinds of assisted technology.
Great. Deb would like to know what recommendations you can provide to help young adults with FASD live independently, safely.
Deb, that's a $64 million question. Now, we are early in the field in Massachusetts. We're just now developing a list of FASD-informed diagnosticians. In Massachusetts, what we're doing right now is we have partnered with the William James College of Professional Psychology. Because we have so few people that can diagnose this disorder, we have some pediatric developmental and behavioral physicians, we have geneticists, but we have very few behavioral health diagnosticians, and now that we have the DSM-5, so we can now train people. So we're developing skills in diagnosing. We have nothing right now for young adults other than the Parent Support Network. There are a couple of live-in residential homes in the country for young adults to live with supervision. What we're hoping to do in the fall is work with the William James College. They have some fellows in the psychology program who are willing to help organize a gathering for young adults to meet with each other under supervision for some socialization. We're far behind, sadly. However, people can always contact me should they want any information about the kinds of interventions that are possible.
Okay. Andrew would like to know, can children receive similar disorders to FASD from other substances such as marijuana, tobacco, cocaine?
No. The only way you can get anything like an FASD is by alcohol exposure. Now, if you have children who were prenatally exposed to, say, just tobacco, we do know that they have difficulty in development, and that they often have some physical problems such as lungs, asthma, breathing issues. They do have some quite a few developmental delays. Marijuana, we don't have a lot of information yet. Most of the studies done for children with prenatal marijuana exposure have been done years ago when the marijuana isn't as strong as it is now. It's not the hippies of the 60s marijuana. It's much stronger, and those studies we just haven't caught up with us. We do know that there is a greater risk, however, for moms who are using marijuana postnatally because it has been shown that everyone is less attentive to immediate needs of children around them when they're under the influence of marijuana and other drugs of choice.
Okay. Brett wanted to know, are there experts in the field who can diagnose or evaluate for FASD in Western Mass?
Yes, there are in Western Mass. At Bay State Medical Center in Springfield, I don't know about the Franklin setting. In Springfield, you have a wonderful developmental behavioral pediatrician there and a wonderful geneticist that are great. We've worked with them before. I have a list of diagnosticians across the state. It's a pretty skimpy list. So if any of you know anyone who's a good diagnostician, please let me know so I can add them to the list.
Okay, let's see if we have any other questions. We do have someone, Deb, who asks, what professional makes the FASD diagnosis, a neurologist or a psychiatrist?
Very good question. All of the above. It could be a psychiatrist, it could be a neuropsychologist, a neurologist, a mental health clinician, a developmental pediatrician. It could be, oddly enough, we get a lot of diagnoses from dentists because the alcohol was damaging the brain and the skull and the bones as the fetus was developing, and so that's why you get some dysmorphic features, and often dentists do this. Nutritionists can also. It's a whole variety of specialists. However, they need to know what they're looking for.
This is from Nancy, and it's more of a comment. It says that this can be very discouraging and cause low self-esteem.
Absolutely. It sounds like some of you have experience with FASD. And there's a very high rate of suicide attempts. in this population. And so if you get a chance to look at the Recovering Hope video that you couldn't see today, maybe there you'll see Kathy, who is a birth mom. And her daughter wasn't diagnosed till she was 16. And by that time, Kathy had been in recovery from her alcoholism for many years. And after Kathy got over the initial heartbreak of realizing that her drinking permanently damaged her daughter, she got herself together and she went back home, and she said, they had a family meeting. They said, for 16 years we've talked about what Carly cannot do. Now we're going to only talk about what Carly can do and build on her strengths. So what we need to do with people with an FASD is help identify and help them identify what their strengths are and go with that. We find a lot of young people with FASD love to work with animals, horses, or in an animal shelter. They love working with children with supervision. There's a lot of things that different people like, and so you're right. Find out what they like and then just shower them with affirmations and positive feedback.
Great. Let's see. I think we have another question from Deb. At what age will emotional age coincide with chronological age?
Probably never.
Okay.
And meanwhile, while we have just a couple minutes left, if you have any suggestions for our task force, you can also submit suggestions to us. I will tell you that we're working hard to get schools involved in learning about this. I do a lot of work with school nurses and school-based health centers on how to talk about alcohol and drugs with students. FASD prevention is in all of that.
Great. All right, it looks like we have time for one more question,
okay.
And that
is...
is...
I have a couple more slides.
Oh, okay. Oh, okay. And so this is from Nancy. I believe it's from Nancy. It says, are children or youth diagnosed with FASD more vulnerable to abuse or substance abuse as adults?
Yes.
Oh, that was from Brent.
Yes, that's true, Brent. They are more vulnerable to abuse and substance abuse. Shall I finish then?
Yes.
So I like this as a media campaign from Minnesota that has a very high rate of binge drinking. And, of course, who's going to give a little child these drinks? No one. So here's some final messages. Be positive, as we just mentioned. Get a diagnosis. And if any of you have children who are receiving services from the community-based health initiative, is it CBHI? Talk to them, because I've been training a lot of those folks to make have interventions. This is Carly. I just talked to you about Carly, who was diagnosed at 16. She loves to draw. And so when she was 22, she drew this, and this is now the national logo for the National Organization on FAS. And you can see it doesn't look like a 22-year-old drawing, but now this is building on Carly's strengths. This is my nephew and my little adopted granddaughter. Now, Matthew in this picture was in his first year as an intern in family medicine at Boston Medical Center. And he and Lana and I had dinner that night. He's not Lana's father. And Matthew said, oh, it's so exciting. I was walking by the hospital this morning, and I passed two women who were pushing baby strollers filled with babies that I delivered. And at the next moment, Lana, who's 3 years old, peeped up and said, pregnant women should not drink alcohol. And I said, what have I done to you, honey? The point is, you all now have that message. And so it's your job to make sure that your friends and colleagues have the message too. There is no safe amount of alcohol to drink during pregnancy. Here are some resources, And I'll turn it over to Renee. Thank you for your participation.
Well, great. Thank you, Enid. That was very informative, and it appears everyone with all the questions really enjoyed it. And as we stated earlier, we can send along some resources following the webinar, but we really appreciate it today. Just a reminder that our Making a Difference conference for RTSC will be held on November 10th at the Best Western Royal Plaza Hotel. Registration is open, but it is filling up, so we'd like you to jump online now and register as soon as you can. It is offered for free for SESPs and for DCF-involved foster and adoptive parents. For professionals, we're asking just a small fee to help defray the cost. So if you haven't registered, please jump on today and support the program. Thank you for attending, and we look forward to seeing you next month.